So welcome everyone. We are going to be talking about behavioral emergencies. It's the February CME for 2023. I have a special guest today, Jeff Bell, one of our paramedic specialists here in Whitehorse. Jeff, do you want to introduce yourself a little bit?
Absolutely happy to be here. Yep, so my name is Jeff Bell. I've been a paramedic for 13 years. I'm also a youth addictions counselor, and I began practicing that in a casual capacity in 2017 in Winnipeg, Manitoba.
All right. And with your youth addiction counselor, that's the main reason that I brought you in on this one for the behavioral emergencies. I really want to lean on your expertise
Absolutely.
in that area and your experience. So the first thing we're going to talk about is just kind of an introduction of the concept. What is a mental health problem? What is a behavioral emergency?
Absolutely. I think to put it in perspective, a mental health emergency is every bit as much of an emergency as something that we, as paramedics, encounter. Academically, much like a diabetic emergency or cardiac emergency or respiratory emergency, but it's viewed differently, right? Where people may be going through mental health emergencies, and given that mental health emergencies are much more subtle, right, or much more complex, I find that we as pre-hospital care providers really fall short as far as our base knowledge and how to actually accurately treat or effectively treat these mental health emergencies.
Is it? I've always tried to figure that it's part of it is a lack of training. Right?
Absolutely,
We
it
don't
is, yeah.
focus on it a lot in our primary training,
Mm-hmm.
but the other part is that for me personally, going to those emergencies is not necessarily comfortable, and so my goal tends to be to get them to somebody else as quick as possible.
Mm-hmm.
I don't. That may not be the right way to go about it, but it's hard for me to spend a large amount of time on scene. I get almost anxious because it's not my comfort zone.
Mm-hmm. No, that's completely understandable that it's not in your comfort zone, because when we as healthcare providers, we're taught very heavily to rely on reactive medicine, which is, there's a bleed, let's stop it, right? There's this person's short of breath, let's fix it, right? And we follow that trend. But with mental health emergencies, a lot of the time it's not a quick fix, right? It's not something that we have the ability to rectify in that moment, right? It's something that it has to be done by more definitive care and specialists, right? But we as providers still have to treat these as true emergencies, right? And it shouldn't be treated any way else. Mental health emergencies are subjective, much like with other medical emergencies, right?
Yeah.
Somebody can get a cut to their hand, and that's an emergency, and other people can have a bone sticking out of their leg, and that's an emergency to them, right? The thing is with mental health, a lot of the time that it doesn't present as obviously as traumatic and other medical emergencies.
One of the things that people tend to do is they tend to view people with mental health as that's their whole being, right? You have depression, so that's you're completely a depression person.
Mm-hmm.
And I think that medics sometimes have that stigmatization as well of mental health issues.
Mm-hmm.
Have you found a way to address that with medics?
It's interesting when you put it that way. I think the biggest thing with true mental health emergencies, not just emergencies, but mental health in general, and dealing with different disorders, is we can't approach it to the same degree that we do with other medical emergencies, right? Let me give you an example. So if we show up to someone's house and they're, say, feeling suicidal, right? They haven't taken anything, they're feeling suicidal, they're going through some very serious personal life stuff, personal life issues. We as paramedics showing up and presenting ourselves as that professional. Sometimes we have the what's the word I'm looking for? Sometimes we can present as authoritative. Thank you. Authoritative, where it may actually inflame the person's current situation. We need to treat the person first, right? Which is, we're not going to be running to the vital machine to check their blood pressure and their oxygen saturation levels and things like that, right? It's all about being approachable and presenting yourself just as a person who cares, just as somebody that wants to be the best advocate that they possibly can be for that patient. The biggest thing we as paramedics can change is our approach. Is that initial first impression approach to that situation, via whether it's a medical emergency or a mental health emergency, right? It's still a medical emergency if it's a mental health emergency, right? But
yeah, I mean, we break down like trauma emergencies versus medical emergencies. So I think that you could say mental health falls under a medical emergency,
agree, yes.
But it does kind of stand apart in that the pathophysiology, the chemistry and stuff is nothing we can touch.
Absolutely.
Right? I can't put a bandage on someone's head and expect it to help their brain.
Yeah, absolutely.
but when you talked about the vitals and stuff like that, I found that a lot of times when I'm dealing, especially with like a suicidal patient or a patient who's just in a hyper depressive state, I don't get vitals ever.
Absolutely.
And, like, I'll transport them the entire way. I had a call recently actually where I transported a patient having homicidal ideations, which actually isn't super normal.
No, not at all.
But I did not take a single vital. I didn't even get the patient's jacket off. Patient wanted to sleep on the bed. I let her sleep the whole way. It was a long transport as well. It was an hour and a half transport. And while I didn't get to do much, I wasn't busy. Knowing that I don't have to get vitals on those patients, made it easier.
So, I mean, you yourself, Ryan, you're a very experienced provider, right? When you compare that to somebody who may be more junior in their career, what can you tell us about the clinical presentation of this patient, this individual that you explained had the homicidal ideation, right? But you didn't feel the need to get that vital assessment, right? How did they clinically present that gave you that comfort, knowing that that wasn't something that was maybe pertinent in that time, and also, what are the adverse effects of you maybe going in there and to trying to take these vital signs on patients like that?
So when I encountered the patient, she was already agitated, having to go from one warm area to another. So we went through the cold, and that caused her agitation. She was complaining instantly about that. She had 2 jackets on, she had snow pants on, and I had the ambulance relatively warm already. When I always try to make that human connection, right? Hey, I'm Ryan. I'm going to be the medic in the back with you today.
Absolutely.
Let's, what are you going to be more comfortable? And it was just, I was not getting through. There was the standoffishness. Didn't want to be touched. Didn't want to be have anyone even really in a pretty close bubble or a pretty large bubble for a patient. So like I couldn't buckle her seatbelt for her because that was too close to her. And she verbalized it for me. Don't touch me. Don't buckle me up. I'll buckle myself up. That kind of thing. So, one of the first things to do is try to get people more comfortable in the back of the ambulance, take off their jacket, because it is warmer than it is outside.
Absolutely.
Absolutely refused. So, at that point, I knew I wasn't going to get vitals, because I'm not going to get a blood pressure through 2 jackets.
Yep.
It's just not going to happen. And she's talking to me. She's got decent color. She's obviously ambulatory.
Yep.
Her vitals aren't going to tell me anything, in my opinion.
Absolutely no, and I think you did a great job of painting that picture of where you looked at how the person is clinically presenting, right? Are they speaking full sentences? What is their color? What's their mentation, right? Are they ambulatory with a normal gait? Is there any obvious injuries? Have they injured themselves, right? All of these things paint that clinical presentation, that clinical picture that's going to basically give you that comfort in, do I need to actually get these values or not? Because being intrusive, because getting vital signs on different people is intrusive, right? It's an intrusive action, especially if you're not getting consent to do so, right? You shouldn't be doing it if you're not getting consent, right? But at the same time, sometimes as practitioners, we don't even think, right? We grab the blood pressure cuff, we go right to the arm kind of thing, right?
Yeah.
It's important, especially with people experiencing mental health emergencies, that we're very, we keep them very informed as to everything that we're doing, right? Much like you were explaining. I think that that summarized it beautifully. That it's not the numbers that we're looking after here. It's the patient's general demeanor,
Right.
and focusing heavily on nonverbal kind of behavior cues. And even if you were to get, let's say, some vital values, or some vital sign values out of that patient, a lot of the time it's going to be clinical. The range is going to reflect the clinical relevance of, or the clinical picture, right? So
Yeah.
if the person is hyperventilating, or if they're tachypnic, or if they're having, say, like an anxiety attack, they're going to be tachycardic,
Yeah.
right? You may find them even on the more extreme ends of having like carpopedal spasms, right? Because
Yeah.
they're blowing off so much CO2, right?
Yeah.
And they're actually hypocapnic, I guess, right? Yeah. A lot of the time, statistically, when we're dealing with a mental health emergency, it's a patient who just wants to be heard, right? It's somebody that you just want to really enforce, or reinforce the use of active listening, right? Hear their side, hear what they're going through, right? In traditional medicine, it's a load and go situation, right? It's
Right.
we load the person up, we package them up, we get them out the door. In dealing with the spectrum that is mental health, we really need to focus on that there is no time limit. You know what I mean? We're not on the clock when we're on scene. We can use those active listening skills. We can think outside of the box, right? We can look at other supports that this person may or may not require at that point in time, and enact those, right?
Yeah.
We can take off the one hat of reactive medicine, right? We're here, we're going to fix this, let's get you on the stretcher, let's go, to let's sit down, let's hear what you have to say, and let's work around this to get you, again, acting within the realm of being the best advocate, right? And that's why it doesn't matter what patient you're dealing with, right? When you talk about benevolence and beneficence, right? It's how are we going to give the person the best care that we ourselves would want, right? In a similar situation.
The leadership team wants us to be on scene as long as we need to be on scene. And they've said it out loud and they put it in writing. And I think that that's important to emphasize for people.
Absolutely.
Is that they can take the time they need to make sure that the patient is comfortable getting on to the ambulance.
Absolutely.
And that, I mean, there's going to be times when you don't have a choice. The RCMP have already formed this person, and they just are not comfortable transporting him in their rig. They want to put him in your ambulance, and they're going to come with you, and they're going to, they could very well be in handcuffs. That's going to happen, and those ones, you're going to end up with probably less time on scene, right? Someone already made the decision for them and you. Nothing you can really do about that. Still treat the patient right, still advocate for him, but they're going whether they want to or not.
Absolutely. Yeah, I think that's a great point. I mean, I would even venture to say, like, when it comes to people experiencing like a drug use crisis or an addiction crisis, getting a short egress is wishful thinking, right? Usually, there's a lot of things that has to be that they have to go through on scene, or a lot of things they have to collect or think that they're collecting, right? So sometimes us. Really getting on their case about, like, well, let's hurry up, we got to get out of here, kind of thing. That's really only going to exacerbate things and inflame things.
I guess talking about the RCMP forming people, and it really kind of leads into the next slide of what defines a abnormal behavior. That really is the hallmark of most mental health emergencies, is their behavior or their thought patterns are not within whatever the realm of normal is.
Absolutely.
And in the book, it talks about how that concept of what falls within that normal range is highly debated, even now.
Well, I think the word normal is a dangerous word, right? Because it generalizes things, right? Where my normal might be different from your normal, might be different from Susie's or Stacy's or whoever else, they're normal. The reality is that when it comes to the word, like, we're talking about emergencies, right?
Right.
What is an emergency? An emergency is something where there is a threat to A, the patient's own health, or B, a threat to others, right? Now, there's a lot of benign behavior that we can observe that is going to be bizarre, right? Or it's going to deviate from what me or you may consider normal,
Yeah.
right? But it's not going to pose that immediate threat to their health or to the health of others, right? And that's where we deviate between, what is an emergency, what is not an emergency, right?
That's a good description.
Yeah. I mean, if we're determining that you've identified, right, that they say, let's say they are hypothetically a risk to themselves or a risk to others, right,
Okay.
and the safety of themselves, safety of others. Determining at that point whether they're voluntary or involuntary is the key in this, right? If they're voluntary and they're willing to come with you and seek that definitive care, right, be transported, the involvement of RCMP is up to the discretion of the provider, and in most cases, unless there is a safety risk to the provider, is not something that's going to be required, especially if the person's voluntary, right?
Yeah.
They're making the decision to seek help. It gets a little bit more complex when we have somebody who's involuntary, right? So we've made that note that they are a risk to themselves or a risk to others. We've said, hey, we think that it's within your best interest, like to come with us to the hospital, come seek further care, come with us, you can talk to somebody. Nope, I don't want to go, right? And that's where we get into a more kind of complicated situation where, it's either going to take a little bit of verbal judo, right? Either verbal de-escalation or NVCI, or assist training to try to reason with the individual, with the patient to come with you, right? And then obviously with the end result of our CMP involvement, if you're not able to get that person to voluntarily come with you. And the thing is, it gets even more complicated than that, where let's say the RCMP show up and they feel that the person doesn't fit the same criteria that you believe that they do, right? Maybe you observed a behavior or heard a comment that the RCMP were not present for, and now your patient is adamantly denying that they ever said that, right?
Yeah.
And presenting very differently to the RCMP than they had presented to you, right? So you can see where a situation like that is so fluid, and it can change on a dime, especially when you're dealing with multiple agencies, and a little bit of a he said she said battle can kind of occur.
Yeah. No, that makes sense. I think it's important to remember that there are some things that mimic behavioral emergencies as well that are a more traditional medical emergency that we can intervene in. I think the number one mimicker is diabetic emergencies.
Mm-hmm.
So if there's any vital that we can get, I really think that the one of the most important ones is what's the sugar.
Absolutely, yeah. I mean, anytime you have somebody altered, right? Or
Yeah.
I mean, as you said it, right. One of the most common signs and symptoms of hypoglycemia, right, is kind of intoxicated behavior, right?
Yeah.
Maybe saying some silly things, maybe doing some silly things. I can actually even say, from my working experience, I had a partner in the past who actually was a diabetic, and his sugar ran low mid-shift. And we were actually going to a call. I didn't know this. We were going to a call, and we got on scene. And he got out of the passenger seat, and he walked around the ambulance 4 times before I asked him what he was doing, because he was like, oh, I was going to get the bag, But little did he know, right? He walked around the truck 4 times,
Yeah.
And it appeared bizarre to me, right? But absolutely, that's a very good point.
We talk a lot about like the suicidal ideation and the self-harm and drug use as well, but a lot of these are even more pathological in that it's nothing that the patient did to themselves.
Absolutely.
They just have the inability to comprehend what's happening. They aren't connected to the same reality we are.
Oh, absolutely.
And such as Alzheimer's, for example.
Yep.
So that's a great example of one that happens to a lot of people, and there's no treatment for it. There's nothing we're going to be able to do for it. We just need to recognize it, treat the patient as humanely as possible.
Absolutely.
And get them to the care that they need, because it's possible they're in their family's house and their family can't take care of them anymore. They're not able to monitor them safely. They eventually need to get to a long-term care facility. And while that transition is happening, we're going to end up seeing that patient a lot. And then once they get to the proper facility or in-home care or even training for the family, we'll see them way less. but we're going to have those patients kind of come and go throughout our careers, especially if we work in the same place for a long time.
Absolutely. No, I think that was a great summary there.
It can be frustrating for us to have to deal with the same patient over and over again. Mm-hmm. It can be frustrating for the family to have to see us over and over again. I think a big part that we forget in the smaller communities too is that a lot of times the practitioners are going to know that person.
100%.
And they're going to watch that decline. So it's going to be hard on the practitioners from that aspect as well. And I think that we need to make sure people are aware that's going to happen.
No, absolutely. I think something to really take into account is, we as providers and pre-hospital care providers, we have this it's only human to get a little jaded, right, or to get complacent when you're dealing with the same patient. Let's say the same patient and the same complaint over and over and over again, sometimes on a multiple times a day basis, right? Mm-hmm. But we really have to do our due diligence, take a step back, look at the whole picture, and understand that patient, that individual, is not accessing our services to be,
ornery?
Yeah,
obnoxious?
Yeah, I was going to say, it's not like I'm trying to think of the word.
Malicious?
Yeah, malicious. There's no malicious intent towards their frequent access, right? What it is this person is truly, in their mind, experiencing this emergency. They are out of options. They need help now. Now, from our perspective, right, and now our level of experience, or whoever's level of experience, right, you may come across this patient and go, oh, that's not an emergency. It's like, well, that's actually not our decision to make, right? What is and what is not emergencies, right? I mean, we have a lot of people in the communities of the Yukon that suffer from a variety of mental health disorders, where even just being in their home where they live, suddenly, very acutely, feels strange to them. And they don't want to be there. And that right there is a crisis to them. That's an emergency, right?
I guess that goes into the conversation we were having about what defines a behavioral emergency. Mm-hmm. And the fact that the patient called 911 is a definition of that.
Absolutely it is.
Part of it is the recognition by the patient that this is an emergency.
Absolutely.
One of the things it says on the slide here, I'm on Emergencies 2 of 2, it says that you'll have panic on the part of the patient, but you'll also very possibly have to deal with the family and the bystanders. Mm-hmm. They're going to be panicked as well, especially if this is not a normal thing for the patient. I've had the opposite, where the patient calls us all the time. The family doesn't even care. Mm-hmm. They'll be sitting on the couch and be like, yeah, she's up there.
Yeah, 100%.
Oh, he's in his room having his freak out. And that I find almost harder to deal with, what it is, especially when it's even something that I recognize as an emergency, than the family members who are freaking out. Mm-hmm. Personally,
it can complicate things, Ryan. I mean, there as you said, there are some calls you attend and the family is neither here nor there about it. The person's in the back, go get him, kind of thing, or they're fairly disengaged from the situation. Mm-hmm. Then you get at the polar opposite, right, where the family is actually the primary concern when you're on scene, right? It's not so much the patient, it's the family, right? Because when we're talking about mental health and varying degrees of mental health emergencies, right, or various states of intoxication, or various, like the various substances on board, when you involve family, a lot of the time there's a family complex going on and family dynamic going on that we don't know about, right, that we're ignorant to because we don't live in that home. We don't understand the dynamic and the relationships and the complexities of that. But I've been on many calls where getting the patient and family members or bystanders separated from themselves is that's the hardest task of the call, right? Is just to separate the two, say, inflaming parties, and then separating and letting both parties, relax, because a lot of the times, yes, these can be very taxing emotionally for family members, friends and family members and bystanders, not just the patient, right?
Yeah. And you might end up having to bring RCMP for that reason.
Absolutely. Crowd control. Yeah. Right? Anytime there's any concern over, can we adequately handle the situation, right? Whether there's one responder or whether there's two responders, right? or more than that, but we'll stick with one or two responders, right? If we feel that this is getting out of hand, that our efforts at de-escalating a situation is not being received well, there should be zero hesitation to involve the RCMP, right? Because at the end of the day, it comes down to our safety, right, and the safety of the patient and the safety of others.
Yeah. I found that a lot of times when there's an emergency of any kind, behavioral or otherwise, depending on the culture that you're dealing with, if it's First Nations, if it's Filipino, if it's Indian, all of those are going to have a different reaction from the family.
Absolutely.
And you might have trouble, like you were saying, separating them to transport. You might have to take a family member with you in the back if it's safe to do so. That might be the best way to get them in the back. Is like,
absolutely.
Who do you trust? Who do you want to be back there to be your advocate? And I've seen, there's a lot of different cultures here in the Yukon. A lot of them. A lot of people from different countries, different backgrounds. You really have to pay attention to the whole scene to get an idea of how you're going to be able to interact with these people.
It's something that we always have to be cognizant of, right? There are certain cultural norms where eye contact, direct eye contact is not something that's favorable, right? You may find a patient or family member shying away. Some of this is gendered, some of this is not. It's really important, and this is where I always fall back on. Take notice to non-verbal behavior cues, right? Yeah. And really deviate your approach based on that. They say on the tree of communication, spoken word is actually the least effective as far as actually expressing one's feelings. Looking at non-verbal cues, and then the whole situation is much more effective.
Yeah. Let's move into some of the different things that can cause these emergencies, some of the different pathologies. Yeah. Dementia. We'll start with that one. It's irreversible. It's incurable.
Yep.
What are we going to do as practitioners when we approach these patients with dementia?
We're going to approach with an open mind and a caring demeanor, right?
Yeah.
Where when you're dealing with patients with either long-term or acute, because you can have the acute setting as well as the more chronic setting, or chronic condition of dementia versus the acute, reassuring them that they're in a safe place, right? That you are there to help, right? Those are really the biggest things, and then making general conversation with them. They may be confused as to why you're here.
They may have even called you.
Absolutely.
And they can't remember it. And so they have no idea why they're there. I think
that's a great point, yeah.
They may be confused about where they are now or why they're there. They may think that they're somewhere else. I've had patients, dementia patients, and you talk to them and you're like, all right, so, where do you live? Oh, I live in Newfoundland, and just over there on whatever street, and, well, where are you now? I'm there. I'm at my house in Newfoundland. Yep. All right.
In that right there, that's the point. No, that's the point. Is you don't want to conflict. And if the patient wants to express that they're right now in Hawaii, then they're in Hawaii. You know, and you're supporting their own thoughts and beliefs regarding where they're at. It's when people can get, or providers can get argumentative or conflicting with these beliefs, where a situation can really become inflamed and blown out of proportion for no reason whatsoever.
Yeah. Let's talk about Alzheimer's.
Let's talk about it. This is a physiological difference in the brain, right? Nothing that we can assess differently. Both have the same, kind of memory loss, reasoning decline, behavioral decline, agitation, and they all cover the same bases. However, anything related to any one of those can be classified as dementia, but Alzheimer's is a specific brain disease that leads to further presenting dementia symptoms.
Right. The thing that seems to be kind of specific to Alzheimer's that you're going to start having problems with your neuromuscular control as well.
Absolutely.
You're going to have trouble speaking, you're going to have trouble swallowing, and you're going to have trouble walking.
Yeah.
So as these get worse and worse, we're going to start seeing that. We might actually go to these patients not because of a behavioral problem, but because they choked.
Absolutely. Yep.
Because they fell.
Yep. Well, it leads to a total neurological kind of decline, right?
Yeah.
Over time, for sure.
So, we want to bring up a disease that mimics this, that we will end up treating a lot very similarly, but that actually has a treatment that can essentially fix the problem. And you were bringing up about UTIs.
Yeah. So I mean, when we're dealing with the elderly, right, or the geriatric population, something that I can say firsthand, not just firsthand, but something that's outlined quite heavily in academia is geriatric UTIs. Now, when we're dealing with the geriatric population, infectious processes don't present the same way that they would if we had an infection, right? Where we have the fever, we have the temperature spike, right? We may be clammy or flushed. The geriatric population, not all, but we'll say the majority, don't have that thermoregulatory ability. Mm-hmm. So you'll have these UTIs that are kind of festering or deteriorating, but you're not going to have the same systemic response. So what ends up happening is you have the presentation, you have a UTI that is begun, the process, and it is often associated with a delirium, right. That we as care providers will be able to detect. Now, I will always say, always work through your differential and work through the other more acute, highly acute, presenting possibilities such as CVA, TIA, things of that nature. But once you've kind of gone through enough pertinent negatives, you can start looking at the possibility of them having chronic UTIs, right? Female versus male. Female obviously having a shorter urethra, right? Are the care needs being met? Is grandma or grandpa or whoever your patient is, are they getting changed adequately? As frequently as they should be, right?
If they're on, if they have Depends on.
Absolutely, yeah. If they have incontinence garments, right? Are they being changed enough by either home care or the primary care provider, right? So again, that comes back to, are their needs being met, right? But that is something where you may be speaking to a patient in the geriatric population where say you have a son or daughter present, and they say, well, mom, she's usually sharp as a tack, right? And she seems to think we're back in Nova Scotia right now, and I have no idea why. Is she having a stroke? Is she having this, right? Again, that's why it's always important to work through your differential. It's important to look at the more serious medical conditions, such as stroke, such as TIAs, right? When you're dealing with things where there's a change in cognition, change in mentation. But specific to that population, it is very important to look at this as a possible differential. It's something that does present this way with the geriatric population, but you will not see that with the younger generations.
But it's important to remember, too, that because of the way that the geriatric pathophysiology is, it is still an active emergency that needs to be treated because sepsis is a real possibility, and once they go septic, the chances of survival is very low.
Absolutely, and that's a very good point, Ryan. The thing is too is that there are a lot of very independent elders in the community, right? Mm-hmm. And you can imagine one of these elders contracting this UTI, which is only going to progress in its own pathology, right?
Yeah.
And then they become now confused to person, place, time, and event, and unable to meet their basic needs of life or life needs.
Yeah.
And you can see how fast things can precipitate from there. You could go from one day them, a patient being functional at home, being able to meet all their needs, to 3 days later, not drinking, not eating, and obviously having that delirium, that acute confusion in their home does pose a risk to their life.
Yeah, this is one of the places where having family around is a big benefit.
100%.
And one of the benefits that the EMRs in the communities are going to have is they may know this patient. They may know that this person sharp is attacked normally. So you actually have a leg above those of us who practice in an area with a higher population where we can't have that personal relationship with as many people. So, we're going to use family to do our assessment. Is this normal for your grandma or whatever? But we're also going to use our personal knowledge and bring that in. And it's kind of a double-edged sword.
Yep.
But it really is going to benefit you in this situation.
I think Ryan just summed it up beautifully there, where when we're dealing with somebody that we don't know, we want a baseline, right? Yeah. How are we going to get that baseline? We're going to ask people that know, right? We're going to ask that third party, that family member, that care provider. We're going to ask them, what is their base mentation, right? Is this normal for them? Now, sometimes you might get an answer, which is, we have good days and we have bad days. That's a very common one. Oh, some days are worse than others, right? But for these acute issues, such as the presenting UTIs, it's going to give you a really good baseline, and therefore it's going to kind of lead your differential in that direction.
Yeah. So moving away from primarily geriatric disorders, we're going to talk about some more generalized disorders. And first one is generalized anxiety disorder.
Absolutely. Okay.
This is where someone worries about everything.
Yeah. Absolutely.
They're just an anxious person. I have family members like this. I have seen many patients who are just worried, and when that escalates to the point of them not being able to cope anymore, that's when we tend to get involved.
Absolutely.
This is one of those ones where a higher level of care is going to be helpful. There's some medications that, for example, ALS is going to have that the RN, if you're responding with a nurse, they might have in their arsenal. This is the kind of one that, yes, you can treat it at the EMR level as far as like using the nonverbal interventions to try and calm the situation, using verbal interventions to calm the situation, and breathing and stuff like that. But it might benefit you if you have a nurse to transport with you.
Absolutely.
To have them come with.
Yeah, I think, Ryan, again, you made an excellent point there, where as an EMR, you still have the ability to be very effective in these circumstances, right, where using verbal de-escalation techniques, right, a little bit of word judo, right, allowing the person to understand you're there to help, right, and that they can trust you in this moment. Coaching through breathing, like using coach breathing techniques, is important.
It's a big
right?
one.
In through the nose, out through the mouth, right? Watch my breathing, I'll watch your breathing. Kind of let's try to go in sync. Yeah. Very common things. And at a nursing level of care, or at an ALS level of care, obviously benzodiazepines such as Ativan or Valium are looked towards for more of a continued care through these. Even at an ALS level, it's not something that you're going to start with, right?
No.
You're going to start with the same level of care that an EMR can provide, which is the coached breathing, the verbal de-escalation. Another thing you can do is you can get that patient to touch something that they're surrounding, whether it's a chair. They can grab the chair, put their hands on the table, put their hands on the ground, and what that's actually called is a grounding technique, right? Yeah. It allows them to be present in that place, in that moment, right? All of these, can be effective, and they can be not effective, and that's the spectrum, right? Is that it's still worth trying first before we kind of increase the level of care.
With the breathing thing, the one thing I wanted to say is I've had calls where that was all we did for the entire call. We got into the ambulance. We did breathing exercises the entire time. I never took a set of vitals. I never started an IV. I never tried to give meds. We worked on breathing, and that got us to the hospital.
Absolutely.
And so having practicing that in real life is huge. You know, I'm gonna breathe your, like you said, into your nose, count to 4.
Yeah.
Out through your mouth, count to 4. That box breathing.
Yep.
If you can hold it for 4 on each direction, that's going to be huge.
Absolutely. I think it's I hope I'm not jumping ahead, but there is one presentation where if a provider has never seen it, can be quite frightening, and that is when you have a patient in true hyperventil, truly hyperventilating, right? Where you have a person presenting with carpopedal spasms, right?
Yeah.
It's like a weird flexion extension of the hands and the feet.
Yeah.
And Ryan, what is that from again?
Hypocapnia.
Hypocapnia, yeah. So that's low carbon dioxide levels, right? And that's just due to the high rate of their respirations.
Wow.
And it can be resolved, right? It almost basically, to put it in layman's terms, it's like cramping. It's like a muscle cramp for the hands and for the feet, right? It does resolve over time, but when you have a person in that acute situational crisis and they're presenting that way, it can be kind of a scary thing to look at, because you know what? It actually looks like they're actually having a kind of a mini seizure a little bit, right?
Or a stroke.
Or a stroke.
Yeah.
A very good point. Yeah.
Yeah.
So, but again, how do you determine whether or not it's A versus B? Is you give it some time, right? You work through your differential. If there's an improvement in the patient's kind of presentation, then these things should dissipate over time.
Well, the nice thing about hyperventilation is it's very visible.
Absolutely.
So that's a key part. Is, oh, look at that, you're breathing at 60 times a minute. I'm going to guess that's why you're...
Yeah, absolutely.
Let's work on that, see if that gets better.
Yeah, 100%.
Yeah. That does kind of go into panic disorder, which is
does.
the next one on our list. You're going to see a lot of that hyperventilation with panic disorder. You're going to see these... When people are suffering from this, they're going to have a sudden fear or dread. Mm-hmm. So the fact that it's not a chronic condition generally, right? It's something that's come on. Could be an external source that causes it.
Yep.
Could be actually a true threat. It doesn't matter though if it's true or not, because in their mind it is. Mm-hmm. And they're going to have all of those sympathetic responses that anybody's going to have in a threatening situation. They could freeze, they could fight, they could run. Any of those are going to happen, and you need to be prepared for that as well.
Absolutely, and I think the big takeaway from panic disorders, right, is it's an unhealthy coping mechanism in a lot of circumstances, right? Mm-hmm. Where other individuals may have more healthy ways of coping with external and internal stressors, right? This is not necessarily just a situational thing, right? This is a disease process in itself, but as it says, on the slide here for management, it's separate from panicky bystanders, right? So anybody else inflaming the situation, you want to definitely provide some separation there. Providing a calm environment, right? Be tolerant, reassure them that everything's going to be okay, right? Or not that everything's, I think I'll rephrase that. Do not reassure them that everything's going to be okay. Reassure them that you're there to help and that you're going to do everything in your power to assist them in this, right? Because the reality is we don't know if everything's going to be okay.
Like I said, this could be a very real threat.
Absolutely.
That we can't mitigate.
Yeah, absolutely.
Patients who are having panic attacks, they need to get seen by a professional.
Absolutely. We don't necessarily need to always transport these patients, right? Because in circumstances where they have had an acute situational crisis, where like a panic attack or an anxiety attack has occurred, and we've de-escalated the situation to a certain degree, if they have a competent adult with them that they would feel more comfortable attending the health center or attending hospital with, that is something we can look at. Sometimes the idea of being in the ambulance further exacerbates things.
Oh, fair enough.
I find clinically that if we do have a patient presenting this way, and we've curbed the increase in panic or anxiety, and we're managing it, that if they don't want to come with us, to obviously you want to advise them to seek that definitive level of care, right, to be seen. But again, it doesn't always have to be with us, right?
Yeah. Let's talk about post-traumatic stress disorder.
Yeah, so I mean, post-traumatic stress disorder, it's a very complex disorder, one that generally takes the diagnosis from a psychiatrist, right? Generally, a patient's gone through a lot of counseling, a lot of debriefing on what has happened, and so we're not going to have a differential for this in the field. It's not something we're going to show up. Oh, this looks like PTSD, right?
Yeah.
And the thing is too, it's right in the name where it's post-traumatic stress disorder, right? So even if we encounter, say, an acutely stressful call or acutely stressful situation, it's not something we can't look at a patient and go, oh, you're probably going to have PTSD from this, right?
Yeah.
Because everybody copes with things differently. Generally, if we do encounter PTSD in the field, it's going to be a patient who is suffering from a complication of PTSD, such as maybe a panic disorder associated with the PTSD, and they're going to make us aware.
Yeah.
They say, hey, I have PTSD. I've been having a lot of flashbacks lately. This is what I'm doing about it. Or maybe I ran out of my medication. Maybe I can't get a hold of my psychiatrist or my counseling services,
Yeah.
But as far as care from us, it's just going to be that, again, that supportive, reassuring, calm environment, right? And allowing them to have, where applicable, direct say in where they would like their care to go. If they did call 911 specific to this PTSD, it definitely does warrant investigation.
Yeah. I think the biggest thing, they may have triggers.
Absolutely.
You aren't going to know what they are.
Mm-hmm.
You may have to ask. They may just tell you. And try to avoid those triggers. If one of their triggers is lights and sirens, don't use lights and sirens.
Absolutely.
If one of those triggers is being touched, don't touch them.
Yeah, bright lights in the back, keep it dim.
Yeah. So this is going to be a lot of patient-directed care for a PTSD patient.
Absolutely.
And that's, in my opinion, that's one of the biggest things to remember about PTSD. Mood disorders are the next thing, and mood disorder is the broad over umbrella term. So we're going to go into some of the more specific ones. So depression is the first one.
All right. What can you tell me about depression, Ryan?
To the best of my knowledge, almost everybody will have an episode of depression, whether for 10 minutes or for 10 years.
Yes.
And it's just the brain not coping with something.
Absolutely.
Essentially.
Yeah.
It's more complicated than that, obviously.
No, but that's, and I'm happy to touch on that. I think so. Depression is one of two things. No, and you summarized it well. There is situational or circumstantial depression,
Mm-hmm.
and then there is a chronic pathology related to a depressive state where your brain, the patient's brain, is not receiving adequate levels or balance of serotonin, dopamine, norepinephrine, cortisol. It's all out of whack, right? Generally, everybody in their life, I can't speak for everybody, but everybody to one degree or another suffers from some degree of circumstantial or situational depression. I remember being young. I remember girls breaking up with me, and I remember being very sad about it. It is very normal to feel bad about bad things happening,
Yeah.
right? Or unexpected things, right? Deaths in the family is another common one, right? But where you have true clinical depression or major depressive disorder is where a patient's brain does not receive adequate baseline amounts of happy juice, to put it to put it in layman's terms, right?
Yeah.
It doesn't have enough active endorphins or those feel good hormones to feel good, right? So their baseline is going to be much lower than like what mine or yours would be. They won't feel the same levels of joy or satisfaction out of the things that we would, right? This is why there's so many different mental health medications out there, from MOAIs to selective serotonin reuptake inhibitors, to tricyclics, and they all work to try to help balance an otherwise unbalanced brain when it comes to endorphin levels.
And we don't fully understand this yet.
We don't.
Like,
no.
we being the medical community, the psychiatric community, there's not a 100% understanding of it. I think when it comes to treatment, we're going to typically be dealing with patients who have a chronic or a diagnosis of a depressive disorder.
Mm-hmm.
We're going to, when we get involved, it's going to be bad.
Yeah.
These are people who eventually are going to, if left untreated, if unable to cope on their own, they could end up with suicidal ideation, self-harm, that kind of stuff. And that's what we're trying to avoid by treating them early.
Absolutely.
The other thing that I think is important to recognize is that this isn't just a thing that affects patients. This could affect colleagues. This could affect you. And recognizing the signs and symptoms of depression in yourself, in your colleagues, is arguably as important as being able to treat a patient with it.
Absolutely. And let's talk a little bit about that. I mean, we got, antisocial behavior, reclusiveness, lack of hygiene, or you're not keeping up with hygiene, right? Mm-hmm. Looking at the condition in which the space that they immediately occupy, right? Look at the condition of the room, look at the condition of the house, look at the condition of the person, right?
Yeah.
Are they eating and drinking regularly? All of these things are indicative, they're your indicators into how the person is coping, how the patient is coping, and how well they're coping with their current circumstances.
Yeah. Again, this isn't something we're going to treat in the field.
Yeah.
We're going to be supportive care.
I agree.
I feel like we've gone over supportive care enough that we're...
Absolutely. Yeah.
Leads right into suicidal ideation. This one, we get called to a lot.
Mm-hmm.
In Whitehorse, I've noticed it a lot. I think it's also something that we end up dealing with at a lot of the communities. It's not even population specific.
No, it is not.
There's so many people who they let their depression, that's not even the right word, their depression gets to the point where they can't cope with it anymore, and a lot of times they feel like this is the only answer.
Mm-hmm.
And there's nothing we have in the back of the ambulance that's going to treat this. It's all supportive care. We need to recognize that this is not a situation that we can judge them.
Mm-hmm. Absolutely not. No, being open and unbiased and non-judgmental is really the principle of care we need to provide. Right. Suicidal behavior, suicidal thoughts. It's so generic. Suicidal behavior is so generic, right?
Yeah.
Suicidal thoughts, with suicidal ideation, all these different terms you can say. The key is to understand that if a person is truly suicidal, they're contemplating ending their life, right? That things in their brain, in their mind, are so bad that they're contemplating not living anymore, regardless of how otherwise trivial providers may assess their current situation. That's irrelevant.
Yeah.
Because it's what the patient themselves is going through, right? It's how they're subjectively interpreting their own situation, right?
Yeah.
There's a couple of really important points when we talk about this that we need to define, and that is self-harm versus suicidal or suicidal behavior, right?
Good idea.
So there is circumstances where self-harm is which can be inflicted, say, by burning or by cutting, sometimes in visible areas, sometimes in non-visible areas, right? Is looked at synonymously with suicidal intent, and it is not. And that's something that's very important to note, right? Certain patients with mental health conditions can actually cut and burn and use self-harm as actually an unhealthy coping mechanism.
Yeah.
So it is in no way, shape, or form an intent to end their lives, right? It is a distracting method, right? A distracting method from their other intrusive, say, dark thoughts. And in these patients, when you ask them, are you trying to kill yourself? To put it bluntly, will go, or how are you trying to end your life? We'll say no.
Yeah.
This is I had a really rough day yesterday. I made these cuts on my arm, and these injuries can be. There's a spectrum in how severe they can be. Sometimes they'll be just superficial, right? Sometimes they'll be more severe, requiring a dermabond or sutures or staples, right? But it's never a good thing to assume that all actions of self-harm indicate end of life intent.
Right.
Right. The person wants to end their own lives. However, there is a catch to this, where if we do encounter a patient in the field that has acted on self-harm, we have to actually assess whether this is still an active thought or not. And in generally all cases, the person will have to come with us to the hospital if that action has been put forward. And that's just to ensure the safety of the patient and to ensure that we're not going to be liable for leaving a patient at home who's hurting themselves.
So, Yukon EMS policy. If dispatch gets a call for someone who has expressed suicidal ideation, or from someone who is saying that someone is suicidal, our policy is to send RCMP almost every time. There's some specific conditions that can be met by dispatch, and I'm not a dispatcher, so I'm not going to talk to those. But or they don't send RCMP, but they'll tell you. So usually RCMP will be there, and it's not from a perspective of a illegality. The RCMP there are there to protect the EMS practitioners.
Yes.
They're there for us. And I have found it so helpful to explain that to the patient. Patient comes, or patient calls, RCMP goes, we go. Patient feels almost betrayed. Mm-hmm. Because the police were there, and I didn't ask for police. I asked for the ambulance. And so going in and saying, hey, my name is Ryan, and we're here to help you, and we just want to let you know that the reason the RCMP is here is not because you're being arrested, not because you're necessarily doing something illegal. It's for our protection, because we can't assess the scene before we get here. Mm-hmm. And I find that actually usually helps break the ice with the patient, especially if they have that sense of betrayal.
For sure. Yeah, and it's going to widely be looked at as kind of like a punitive thing, right, when the RCMP show up. And it is unfortunate, but at the same time, again, being transparent with the patient, right, and allowing them to stay informed, where it's like, well, let's say hypothetically on when the call came in, it was, you said you had a knife and you were hurting yourself, or you were going to hurt yourself, and we see now that knife isn't here. Right, but this is just for our safety and for the safety of everyone involved, right? It's complicated, because when you have the a patient displaying suicidal ideation or suicidal thoughts, you also have to determine at what stage, or kind of what stage they're in, right? Where the first one is the ideation, right? The thoughts. And to put it statistically, over 40% of people walking around today have had some form of suicidal thought in their life, right?
Okay.
Over 40%. However, when you couple that with, say, comorbidities with other mental health conditions, and then you factor in, okay, now is there a plan? And that's the next step, right? So the first step is the thoughts. Yeah. The second step is the plan, right? And a plan could be anything from, I'm going to drive my car into a pole, right? Or I'm going to take this bottle of pills. The plan is the second stage, and then the third stage is going to be the act itself, right? The actual attempt. Using those three stages is a great way to gauge not so much the acuity, but where you're at in the process. All three stages are emergencies in themselves, right? But all three stages are important. If you're able to get that information, this is valuable information to who you might be handing that patient off, the patient care off to, right? Because where you may have a rapport with this patient and be able to gather this very valuable information, there's nothing to say that the care provider that you're handing off care to might not have that level of trust and may not able to gather that information, right? So it's very important to define where they're at in the process, right? Have they ever committed acts like this in the past, right? The best way to look at things too is the only kind of history repeats itself, especially when it comes to chronic mental health conditions, right? So, if you're saying you're going to take a bottle of pills, have you done that in the past? What did you do then? And I think what we have to take away from this whole thing, and yes, calls can come in from a third party, meaning, right, that the patient themselves didn't call, right? But when a patient themselves call 911 or get an ambulance to come and help them, that in itself is a cry for help. And that is a preventative measure, right? Because if they didn't want help, they wouldn't have asked. And like I just touched on, though, but that does get complex because there are situations where I can even say clinically where I've experienced, I show up to a house and it's a third party call, from the ex-wife, ex-husband, ex-partner, whoever of the patient who has said, so-and-so has contacted me and they're threatening to do this. And then you present yourself to the prospective patient. You go, hi, my name is so-and-so and we received a call and this is a concern. And they might look at you like, what are you doing? what are you doing here, right? And that's a complexity within the suicidal behavior that I wanted to touch on, because we can respond and we will respond to third-party concerns, right? Sometimes even fourth-party concerns, which I want to touch on, which is like a social media threat, right? Somebody posts something on social media saying they're going to do something, right? That person, that post is then seen by somebody, 911 is called, and then we show up, right? We are only as good as the information the patient provides, right? We are not detectives. We are not there to investigate, if this person did in fact send this text message or make this post. We assess the patient as they present. We go through our assessment and do our due diligence to ensure that they are verbalizing that there is no intent to hurt themselves or others. You know what I mean? That they have no concerns regarding their current status, and then kind of carry on from there. I think that's a very, very important point, though, because a lot of the times, we show up and the patient might even wonder why we're here, why we're there, right? Because they didn't intend for us to ever show up.
I think it's also important to recognize that by asking these very specific questions, do you intend to kill yourself? Do you have a plan? This doesn't, if they say no to this stuff, us asking those questions doesn't put that idea in their head and push them in that direction.
Absolutely. That's a very good point. Yes. No, they're important questions. It's all about how you phrase it, too. I mean, some people, like myself, I prefer to always go with hurt yourself. Because hurt yourself is a big spectrum. It's like, that could mean a little cut. That could mean, going all the way, right? People if you want to use that really, the loaded gun, so to say, of a term, right, is kill yourself, because it's very finite. It's, do you want to kill yourself? Or I find that whether you use that or whether you use do you want to hurt yourself? Do you want to end your life? It depends on how you phrase it, kind of thing. But we have a legal requirement to ask these very emotionally charged questions. And Ryan made a very good point there, where do not think for a second that by asking that you're now putting that thought in their head. We have a requirement to do so, to ask those questions, and if you're already there trending down that path of questioning, it would be erroneous to think that individual probably wouldn't have thought about that themselves.
One more key thing I want to talk about is when you have patients who have attempted to end their life, especially by drugs, medications of any kind, over-the-counter, illicit prescription, whatever it is, bring the bottle, bring any remaining medications with you, and those need to be presented. The other thing too is that when people do use medications, call poison control. A number is in the guidelines or the protocols, and I'll put it on the bottom of the screen as well because I can't remember off the top of my head. It's in all the phones. If your ambulance has a phone, it's been programmed into your phone, and they are an amazing resource. They set up a file for the patient, and you access poison control, get the information you need from an EMS perspective. The next level of care calls poison control. When they know it's the same patient, they actually already have the stuff on file, and they'll fax information to a health center or a hospital. When that patient goes to a hospital, they can call and get the exact same information, but whatever's relevant for their level of care that they can provide. And it's a continuum of care once you initiate it. And man, I've really had good experiences conducting poison control.
Oh, that's great to know. I didn't even know that. Yeah. So, and again, Ryan made an excellent point where, when you have this, the circumstances that meet where a patient has pills right at home, accountability for them is huge, right? I mean, even if somebody says they haven't taken them, it's like, well, yeah, okay, well, let's take them with us anyways. Or you can even do that. Work that into your differential on scene and look at when say bubble pack or prescription bottle was prescribed and how many is in there versus how many should be in there. Those are all really good indications into to what you may be dealing with, right? And complications of like a polypharmacy ingestion or
manic behavior. It's a tough one to really talk about. Typically, if someone's having a manic episode, the call isn't coming from them. We're getting a third-party caller. The people who are manic a lot of times think they're doing great, but it turns out they're not actually doing great.
Absolutely. Well, and the best way to describe this is imagine a brain on fire.
Yeah.
Honestly, it's firing on all cylinders. It's redlining, so to say.
Yeah.
And that's when you have the ups and downs, or the clinical roller coaster that is bipolar disorder, right?
Yeah.
The super highs are very high and the lows are very low, right? When you have somebody exhibiting a manic behavior, energetic, very bombastic and outward in their expression, they may be claiming completely false things like that they're the king of England or things like that. They may have a lot of misplaced confidence in their ability to complete some said thing or said task or multiple tasks at the same time.
Yeah.
And the biggest risk to a patient in this state of mind is just overextending their capabilities, right? Because they're, like I said, it's like their brain's redlining, right? There's so much of a certain endorphin in their brain, right, that it's not regulating, right?
Yeah.
And then on the opposite side of things, you can look at the lows, right, which is the brain was on the manic phase was redlining, right, and then on the low it's almost stalling, right, and both ends of the spectrum have a lack in function, right.
Yeah.
Well, the manic has a lack in function because it's overextending yourself, multiple tasks. Overcommitting, right, is an easy way to put that. But on the other side of things, it's not taking care of yourself, right? Hygiene, basics to life, lying in bed all the time, not having energy to do anything. It's that's really the spectrum of BPD.
Yeah. Another thing that can cause mania is some drugs.
Absolutely.
So it might not be a bipolar disorder. They might have taken a drug that causes this, and it's a temporary situation, and they'd never felt it before, which could cause them to call you, as opposed to it being a third party.
Well, especially if we're dealing with certain stimulants, right?
Yeah.
I mean, like, thank goodness it's not too prevalent up here, but methamphetamine, right? Methamphetamine psychosis and
PCP,
and dissociatives like PCP.
Yeah.
Methamphetamine use has that ability to kind of mask what a manic phase may look like, right? Because of the endless energy and the repetitive tasks and things of that nature. But that's a very good point, Ryan.
All right, I think that's going to end it for this episode. We're not going to have a scenario for this one because it's very hard to do a scenario for psychological or psychiatric disorders, and we're gonna have another video about some other behavioral disorders that we're gonna run into that I think is gonna be super interesting for the next training.
That sounds great.